Thank you for joining iMeet. When you hear the tone, you will be the 12th person to join the meeting. This meeting is now being recorded.
Good evening, everyone, and welcome to our monthly AABIP webinar series. I'm Ara Christian, coming to you from Loma Linda University, and on behalf of my co-moderator, Dr. David Shaw from Harvard UCLA, we're again very excited to bring you a highly anticipated presentation by one of our esteemed colleagues. Today we have a topic that I think has garnered quite a bit of attention of late, but before formal introductions, I'd like to review a few housekeeping matters. First, everyone, please note that this webinar will be recorded. It, along with previous and future webinars, can be viewed on the AABIP website, and this can be found under the Education tab on the front page. Second, we ask that all participants mute their phones during the course of the webinar to minimize the background noise and optimize the overall listening experience for everybody. Alternatively, you can use the volume control icon at the bottom right of your iMeet window. Now, to ask questions or communicate with the group during the webinar, please type them into the chat box. This is the thought bubble icon located in the bottom left of the iMeet window. Now, our presenter today is happy to answer questions as they appear during the talk, but we will also keep track of the questions as they come up and address those that remain unanswered toward the end of the hour in a formal Q&A period. So please feel free to type in your questions at any time. Now, finally, a couple important disclaimers. The AABIP does not endorse any specific technologies or products. Also, the content and views expressed within the webinar represent the opinions of the speaker and do not necessarily reflect those of the AABIP. So without further delay, I'd love to turn it over to Dr. Shaw for our formal introductions today. Dave?
Thank you, Ara. So today we are very pleased to have Dr. Samira Shojaee join us. For those of you who don't know her, she is currently practicing at Virginia Commonwealth University, and she is going to be speaking today for us on the topic of the use of indwelling tunneled pleural catheters, specifically for non-malignant pleural effusion, for which she has a great deal of expertise. So thank you so much for joining us today, Samira, and for sharing your expertise with us.
Hi, David, Ara, thank you so much for having me, and thanks for arranging these webinars. You're doing such a fantastic job. Hello, everyone. I would like to let everybody know, please do write your comments and questions. I wish we could make this as interactive as possible. We're obviously limited with the way that these webinars are usually presented, but I will try to look at the comments, and if I catch all of them, I will answer the questions. If not, then we'll move on and answer the questions at the end. So very quickly, disclosures. I don't have any financial disclosures. I have a small grant from the Chess Foundation, but not related to the topic we're going to discuss today. And then I want to put this one other disclaimer way up front. The quality of the data that we're going to review is going to be mostly retrospective studies. These are small sample size studies. And so I think it's very important for us to review this literature from a very critical eye. There is limited internal and external validity with regards to most of what is being discussed, and there's also limited patient-centric endpoints. And we will keep coming back to that through the discussion. And then finally, I hope that everybody can hear me okay. I'm hoping that David and Ara would speak up if they can't hear me, so I would know that I should speak up. But I'm recovering from a bad bronchitis, and every time that I speak, I cough, which is why if you hear a barking cough in the middle of the presentation, please forgive me. I've been offered many bronchs every day in the bronch suite, and my fellow even tried nebulized lidocaine yesterday to see if this would help for the webinar today. Anyhow, there you go. All right, let's get started. So we're going to briefly we're going to summarize the literature that is there with regards to the utility of IPCs in the two most common causes of non-malignant effusion. These are cardiac-induced and hepatic failure-induced. And then I'll talk to you about the use of IPC with the limitations of the literature that is available in other non-malignant effusions. So why is this important? Why should we even care? Which I think is important to talk about the magnitude of this problem. As you know, pleural effusion is quite common, about 187,000 thoracentesis per year. Many of these are for non-malignant effusions. You'll notice that I'll call, all of these effusions non-malignant. I think if a patient comes into your pleural suite and has a full test with a complete whiteout on one side and is barely breathing and has decompensated heart failure or hepatic failure, often their mortality is actually higher or as bad as a patient with malignant pleural effusion. And so it's hard to call these patients benign effusions, which is why I've elected to use the terminology non-malignant effusion. And most of these effusions generally respond to medical therapy first. In fact, majority of them respond to medical therapy, which is why we will touch base on the utility of IPC in refractory cases of non-malignant effusion. The other reason why this is important is because repeat thoracentesis, which is often the first thing to be used for these patients, is, let's face it, is invasive. From our perspective, it's a very simple procedure, but for a patient who needs to come back every 2 weeks and every 3 weeks to get another thoracentesis, it is invasive from the standpoint of a procedure. More importantly, for factors that we cannot measure from the patient standpoint, is that it is challenging with regards to regular travels, short-lived symptomatic relief, and then many of these patients are on anticoagulation, antiplatelets. They have to keep coming on and off these medicines. And so there's a lot that affects the patient overall. And finally, pleurodesis is even more invasive. And many of these patients are quite frail. Their frailty is going to exclude a big population of these patients from getting pleurodesis. So I'm kind of going to take a backward approach. As opposed to going through the literature, starting with smaller studies and advancing through the literature, I'm going to start with a meta-analysis, which is fairly recent, looking over most of the studies that we will discuss throughout the rest of the talk. The reason why I want to do that is because I want to emphasize the quality of the literature that we have in hand. So this is a study done by Patil and colleagues in 2017. They collected 13 studies. They collected 325 patients from these studies. As you can see on the table, the etiologies are quite variable. Cardiac, hepatic, empyema, and let's face it, all of these are different. Patients act differently. They are even managed differently. So in this next slide, I really don't want you to focus on anything else in the table, with the exception of the type of the study and the quality of this study. So the two arrows up top are where we're going to focus. Every time a meta-analysis is performed, these two variables are reviewed very carefully. As you notice, the type of the studies here are mostly case series, some abstract, and then a few retrospective studies. The quality of the study is regarded as very low because of the risk of bias, selection bias particularly. Now, every time a meta-analysis is performed, there should be a weight assigned to every study that is going to be included for analysis. And as you notice, the very low quality of pretty much all the studies that were available for this analysis makes the measurement of the effect estimates quite inaccurate. So the authors try to represent cardiac-induced spontaneous pleurodesis, and as you can see, these numbers are all over the place because of the differences and variability in the literature. And time to pleurodesis, look all the way to the right here. As you notice, time to pleurodesis is also variable. It ranges from mean of 56 days to mean of 170 days, again, because of the differences in etiology. Another study that I would like to, one more thing, complications, overall 17%. We'll touch base on this later, but this is, again, pooled complications from all sorts of etiologies with all types of responses to tunnel plug catheters. Another study was published in 2014 from Thorax. This is a multi-center study from UK, including 57 patients with IPCs. What I want to point out is, again, this difference in etiology. Overall, the authors found that there was a chance of 33% pleurodesis with a median of 71 days. and complication rate of about 16%. So similar to the prior meta-analysis, but look here again at all the different variable etiologies. The authors noted that hepatic hydrothorax did worse than the other groups, but look how variable these groups are and how small each one of these numbers are. All right, so I think I've tried to really just emphasize before we even start with this topic that our literature is limited and what is wrong with the literature, which is got nothing to do necessarily with the investigations, but with the limitations and working within those limitations that we have. Let's start with a case. So 76-year-old gentleman, he's bedbound, he's decompensated, he's got decompensated heart failure, he's already on the butymin drip, dyspneic, orthopneic. He's been on Lasix drip, which was recently stopped because his creatinine was rising and has progressive renal failure. I'm sure it sounds familiar to most of you. He avoided on 2 thoracentesis on him during the past month, and he has significant symptomatic relief. Let's see what everybody thinks here as you look at these different options. So A, pleurodesis has 80 to 90% success rate in CHF-induced pleural effusion. B, IPCs have a low chance of spontaneous pleurodesis and suboptimal, and so they're suboptimal options. C, medical management in CHF-induced effusion is successful 50% of the time. And D, bilateral pleural effusion due to decompensated heart failure is encountered very frequently. And I encourage you to try to go ahead and put your comments so we could see what everybody's thinking. I don't think I'm seeing any comments on my end. Or are you seeing any comments or any options on your end?
Doesn't look like we have any answers, but
okay.
I'll
good.
play.
I just wanted to make sure that I'm not missing anything. Okay, wonderful. So we're going to discuss each one of these options at length, but very briefly. So pleurodesis has 80 to 90% success rate in CHF-induced pleural effusion. A lot of these answers are just for creating a discussion as opposed to really picking out the right answer. So pleurodesis rate has actually been investigated very infrequently in patients with CHF, and it's mostly in retrospective fashion, and often noted to be less than 80 to 90%, but we will discuss this in a couple of studies that I will show you later on. B, IPCs have a low chance of spontaneous pleurodesis. Based on retrospective studies, this is actually correct, but then it follows to say these are suboptimal. And I think that's where a lot of our focus is going to be through the talk is that if the patient desired outcome is pleurodesis, then yes, they're suboptimal. If the patient just needs to feel better after drainage of the fluid, then this is actually, this may be an optimal option for them. C, medical management with CHF-induced effusion is actually successful far more than 50% of the time, and we'll review the literature in this area. And then D, I see a couple of people picking D as an option. I would probably pick D because there is definitely, it's very common for CHF-induced effusion to be bilateral. So let's look at the literature here. First of all, effusions in the setting of heart failure are quite common, 72 to 87% of patients. And this is from studies looking at huge studies, and some of the national database studies looking at patients' autopsy results as well as pleural effusion in the setting of CT scan and other forms of imaging. And the primary management is medical management, diuresis, and low sodium diet, as you all know. How aggressive, as aggressive as it can get, and how long, as a patient can tolerate it, unless you think that the patient is undergoing renal compromise or they're not responding to diuresis, or that perhaps they need afterload reduction and are not responding to Lasix at all. Once you establish that these patients have refractory diuresis is when you would consider other options. So, excuse me, how often is diuresis going to be helpful? There is a study of 60 patients. This is a prospective study looking at patients with pericardial and pleural effusion. 87% of the population had pleural effusion, and 87% of these had bilateral pleural effusion. This is also confirmed in retrospective but large national database studies, confirming that bilateral effusion is actually quite common, often more than 80% of the time. And in this study, 89% of the patients responded very well to diuresis after 2 weeks of aggressive diuresis. So very, very important key to keep in mind. How about pleurodesis? Is that a good option? I'm going to discuss about 3 studies. One of them is right here, a single-center retrospective study. In this study, they looked at 16 patients only. 75% success rate was reported. So pleurodesis is an option for patients with congestive heart failure, and we look at a couple of bigger studies as opposed to just small studies. All right. So how about repeat thoracentesis? I think it's important to think about this in the setting of cardiac-induced pleural effusion. We don't have data with regards to the risk of repeat thoracentesis in this group. We have data with regards to repeat thoracentesis in hepatic pneumothorax. When I think of repeat thoracentesis in heart failure, my first thought is that a lot of these patients are on antiplatelet or anticoagulations of different sorts, and many of us stop or hold these medications before thoracentesis. The patient has to constantly come on and off these medicines every 2 or 3 weeks. The repercussions of that and the downstream effect of coming off these medicines is really not known and is not studied. So let's take a look at this table. This is actually published quite recently, looking at both hepatic cardiothorax and CHF in the setting of IPCUs, and they've done a good job of collecting some of the studies. What I'm going to do mostly is focus on the quality of the study that is here, and then we'll discuss some of these studies a little bit further. So take a look up front. You notice that David, can you hear me?
Yes.
Okay, great. I think I lost everybody for a second. I don't know if I got disconnected. But what I want to emphasize is, first of all, the type of the studies that are included in this table. The first study by Carnegie is a prospective study. Everything else is retrospective. So this prospective study includes only 5 patients. On the other hand, we have a study of, I think I have gotten disconnected. Can you guys hear me?
So I can hear you, Samira, but let me just clarify which slide you would like to be on.
I'm on slide 19, but oh, there we go. I'm on slide 20, but I think I just lost the slide for a second. Did you guys also lose it?
So yeah, a couple of people noted that. If it's not advancing for you, I can advance it for you manually, and just let me know when you want to move to the next slide.
No, it's not. We're exactly where we want to be. I think the slide just kind of vanished away and then came back up. If everybody can see it, then that's great. So looking at the study under sample size, look that there's only 1 study that is prospective. Everything else here is retrospective. Beside it, where the arrow is pointing, I want to emphasize that most of these studies didn't focus in a prospective fashion on patient-related outcomes. So palliation from patient standpoint was studied in some of the patients, for example here and here, but in some of the studies was not reviewed. Right, so let's look at the first study. This study of 5 patients was done in 2009. I think the authors should be applauded for kind of thinking outside the box in 2009 to use IPCs in the setting of cardiac-induced pleural effusion. What they noted was that everybody improved with regards to their symptoms. However, 2 out of 5 patients actually developed empyema, and 1 of them died as a result of their empyema. The next 2 studies that I would like to discuss are both retrospective studies. One of them is a bit larger, a study by Shojaee and colleagues, and looked at 43 patients. All of these patients had a benefit with regards to their symptom improvement. But again, note that this is a retrospective study. And so as a result, I would imagine that it's hard to go back and take a look at patient symptoms and accurately document that they had significant improvement. I have the same problem again, David. Can you hear me okay?
Yes, I can.
Okay, what I see on this slide says network error. iMeet appears to have lost its connection to the internet. Please check your network connection. I do have a
What I
connection.
can do is I can advance the slides for you because I think the slides are freezing.
Okay. Can everybody else hear me now?
Yes, we can hear you, Samira.
Okay. Well, I apologize. I'm not sure why we're having the poor connection. Okay. So let's keep going. So let's move to the next slide, if you don't mind, David.
Okay, we're on the slide with the study by Freeman.
All right. I do not have connection, but that's okay. I can pull up my actual slides, and if everybody else can follow, then I will ask you to move the slides for me. All right. So if everybody's on the slide with Freeman, this one study I want to point out, I think it deserves to be fleshed out a little bit more carefully. Let's go to the next slide, David, if you'd be so kind. So in the study by Freeman, as you notice, two groups of patients were compared. This is a propensity-matched comparison, comparing pleurodesis during thoracoscopy with tunnel pleural catheters. The reason why I think this is probably a more superior study with regards to the design and the rigor of the study is that they tried to use propensity match to compare the two groups and basically create two groups that are more similar to each other so that they could take away selection bias as much as possible. It's obviously not a prospective analysis and it is not a randomized control trial, but it's pretty nicely done. One thing that the authors have noted here is that they actually had 144 patients in their center who had talc pleurodesis during thoracoscopy. And among those 144 patients, they matched 40 patients to their tunnel pleural catheters. What they noted is that both patients had improvement in their symptoms with regards to palliation. I'm going to refresh your memory again. This is retrospective, so the accuracy of follow-up and symptomatic improvement is always a question, but they clearly defined that there were some improvements in both groups. What they noted, however, was that there was significant morbidity and mortality in the pleurodesis group. Some patients died, some suffered from atrial fibrillation, respiratory insufficiency, and the length of stay was much longer in the patients who had talc pleurodesis. Let's move to the next study, if you don't mind, Ara. All right, so with regards to the last two rows, the studies are by Majid and colleagues. This study looks at two separate arms, and because both arms have used IPC, they have separated them in this table. What they did was they compared thoracoscopy and talc pleurodesis plus IPC, done all at the same time, compared to IPC alone. They had a larger population of patients in the IPC group, and what they noted was that both groups had symptomatic benefit, but the thoracoscopy group actually had a fairly high rate of pleurodesis and over a fairly short time period compared to the tunnel pleural catheter group, which suffered from 7% risk of empyema in addition to lower rate of pleurodesis. Do bear in mind, though, when you look at this study, as opposed to the Freeman study, this study could suffer from significant selection bias. Why was it that some patients, for example, did not go through thoracoscopy? All right, well, let's go to the next slide. I do want to verify one more time, I apologize, from David or Ara. You're on the next slide, which is K2, is that correct?
That's correct.
Okay, because I have absolutely no connection, and I apologize from everybody who is listening because I can't see any of your comments if anybody's asking questions. I'm so sorry. But let's look at this next slide. It's a second case. So we're going to change gears. So we have a 54-year-old gentleman with NASH cirrhosis and hepatic hydrothorax. He's coming back for his third thoracentesis in the past 1 month. You've drained him every time. He's significantly improved with regards to his symptoms. After drainage of 3 liters of fluid, he's had full re-expansion of his lungs, and he has multiple episodes of hepatic encephalopathy, so he's considered to be a poor TIPS candidate. And so he's heard about tunnel pleural catheters. He's asking you about them. Let's move to the next slide. So this next slide is listing some of the possible options that you could give this patient. A says that tunnel pleural catheters are shown to be superior to both TIPS and pleurodesis in the management of hepatic hydrothorax. B, there are no significant risks with repeat thoracentesis, and the current course is most appropriate. C, tunnel pleural catheters can carry a significant infection risk and can lead to mortality in some patients with hepatic hydrothorax. And finally, D, 50% of the time, tunnel pleural catheters can lead to pleurodesis in patients with hepatic hydrothorax. And I do not see any of your comments, but if you want to put your comments, I believe that maybe David and Laura can see.
Yes, so there are several C's and a few D's mixed in.
All right. Okay. So let's look at each one of these, and we'll flesh each one of these out more in more detail. So the first one, there is actually no head-to-head trial looking at tunnel pleural catheters compared to TIPS or pleurodesis. Option B, this risk is actually not known in CHF as we discussed, but the risk of repeat thoracentesis is studied in hepatic hydrothorax and is thought to be higher than other patient populations. And so there is some risk involved with repeat thoracentesis, at least based on our retrospective data. C, I think, is an option that I would probably pick. We do know that tunnel pleural catheters carry an infection risk with patients with hepatic hydrothorax, and there is some mortality involved. We'll review some of the literature. Again, retrospective data, so take all of this literature with some grain of salt. And finally, D, what we know is that the rate of pleurodesis, spontaneous pleurodesis with IPCs, is lower than 50% from most of the retrospective data. But we'll discuss these a little bit further. Let's go to the next slide. Thank you. So hepatic hydrothorax is definitely less common than cardiac-induced effusion. Having said that, the chances of having refractory hepatic hydrothorax is more likely than having refractory cardiac-induced effusion. Up to 26% of the time, people could have refractory hepatic hydrothorax. 85% of the time, they're right-sided. And I think it's important to pay attention to this when you compare this with cardiac-induced effusion. In the setting of cardiac-induced effusion, you drain the right side, you still have effusion on the left side. So you have to deal with two different sides. In CHF, you only deal with the right side most of the time, not all the time. And then there are other reasons for shortness of breath in a patient with cardiac-induced effusion, such as pulmonary edema, which often accompanies pleural effusion. So in a setting of hepatic hydrothorax, you could have bilateral or left-sided effusion, but it's less likely. And then repeat thoracentesis is the common practice. Let's move to the next slide. So I've highlighted in red 1986. This algorithm was put together so many years ago, and honestly, it still holds true today. This is pretty much what most people do in most centers. When a patient has hepatic hydrothorax, they undergo sodium restriction and diuretic therapy, and if they do not respond and are refractory to medical treatment, then they undergo repeat thoracentesis until they get liver transplant, or unless they are TIPS candidates. And I think this is a huge limitation for many of the patients who require frequent thoracentesis. Let's look at the next slide. So this study compared to, remember option A suggested that TIPS has been compared with IPC and pleurodesis. That's actually not true, but there is a study that has looked at medical management alone, which includes repeat thoracentesis in this study, plus diuresis and diet, compared to TIPS and transplant. This is a retrospective study. The value of this study is that it can show you the overall survival and the severe morbidity of this patient population. The downsides are that there is significant selection bias. There are only 5 patients who received transplant. There are 8 patients who underwent TIPS, and most of the patients had medical management, and they did significantly poorly with much lower survival. If you look at the red box here, 321 days was mean survival in about a year. Compared to transplant patients, none of whom had died at the end of the study. All right, let's look at the next slide. So this is a meta-analysis. Don't bother your eyes trying to figure out what this table says. All I want to point out is that there are 8 studies reviewed in this meta-analysis, and on the next slide, we'll see that 332 patients were collected in this meta-analysis. First of all, TIPS is generally an option, or about 50% of the patients are candidates for TIPS. Out of those 50% who receive TIPS, based on this meta-analysis, about 73% of them have success. However, about 56% have complete response, which is great. About 25% have partial response. These populations continue to have occasional requirements for repeat thoracentesis or other management. And then about 27% of the time, patients develop hepatic encephalopathy. 18% die by 30 days. And in 1 year, about 52% of the patients survive. So about half of the patients die. All right, so let's move to the next slide. Since TIPS is not an option for everyone, repeat thoracentesis becomes the primary option in patients with refractory hepatic hydrothorax. This is a study done in 2001. It is a Spanish study looking at the complications of thoracentesis in patients with hepatic hydrothorax. The hypothesis of the authors here was that patients with hepatic hydrothorax have poor coagulation factor synthesis and bone marrow suppression. They're thrombocytopenic, they have elevated INR, and they're more at risk. And what they found was that after the first thoracentesis, about 7.7% of the patients had pneumothorax. Bear in mind, in 2001, this study did not use ultrasound. And then by the fourth thoracentesis, the rate of complication was up to 34%, or about 35%. The downside was that this study did not have a comparison group. So there was nothing in the literature that suggested repeat thoracentesis was not just as harmful in other patient populations. There's another recent study that has looked at hepatic hydrothorax and non-hepatic hydrothorax group. The non-hepatic hydrothorax group had a heterogeneous etiology, so from malignant to non-malignant effusions, with a fairly large number of thoracentesis in the hepatic hydrothorax group, 274 versus 188 in the non-hepatic hydrothorax group. And as you notice, the first thoracentesis complication rate was not significantly different. It was a bit higher in hepatic hydrothorax, but did not reach any significance. But if you look at the second complications, let's go to the next slide. That's a table and a graph. Is that correct?
The next is actually your study from respiration, or are we one too far?
Okay, I'm so sorry. No, I already went through that. That's the one that I was just discussing. Sorry about that. Yeah, so that's the study that I said compares control versus hepatic hydrothorax group. Let's now move on.
Now we have a table and a graph.
Perfect. So we're looking at a table that includes patients' number of thoracentesis and their overall complication rate. So this is not major complications only. This is all complications. And as you notice, complications by thoracentesis number 2 in the hepatic hydrothorax group reaches about 7%, and it goes up to about 10% by thoracentesis number 4, and it's up to about 12% by thoracentesis number 6. Beyond this number, there's really no valuable data, which is why you see a plateau on the chart, and that's because there are not many patients with 8 thoracentesis, for example. But it kind of supports the same thing that was shown in the prior study by Castello and his colleagues. Now, if we move to the next slide, we notice that on multivariate analysis, looking at just the hepatic hydrothorax patients, an elevated MELD score and platelet counts of less than 50,000 were risk factors for hemothorax. And if you look at all the 470 thoracentesis, you know that patients with hepatic hydrothorax were more likely to have any form of complication. In addition to that, the most common or the most important predictor of having a complication was a prior complication with a previous thoracentesis, which was seen in the hepatic hydrothorax group. Now, the positive thing about this study is that it confirms what was shown in the prior study, a rise in hepatic hydrothorax complications related to thoracentesis. But there are many limitations. First, it's single center, so the generalizability is not as well. It's retrospective. It is not controlled for pre-procedure blood product administration. And finally, because of the small number of complications overall, there is a significant limitation in model building. So as you can see, there are a lot of confounders that are not adjusted for here. All right, let's move to the next slide. And if thoracentesis, once repeated numerous times, is harmful, and TIPS is not always successful, what other options are there? What I have here is just the title of some of the studies, because these are mostly case reports. I'm going to look at the last one, which is thoracoscopy and talc-purulage. As you can see, 18 patients were included here. This was done in 2000 and was published in Chest. They showed that immediate efficacy of talc-purulage was about 47%, but mortality was 39%, and morbidity was 57% in 3 months. Since this study, talc-purulage has not been very popular, and there are not many studies beyond small case reports with regards to hepatic hydrothorax management. Excuse me, let's look at the next slide. All right, so we have chest tubes and tunnel pleural catheters. What is wrong with chest tubes? Most of you probably know when you talk to your transplant team that chest tubes are kind of considered taboo in patients with hepatic hydrothorax. If you look at the next slide, you notice that this study is the cause of all the concern about chest tube use in this patient population. This is a study of 59 patients. It is retrospective, as most of the studies we've discussed have been. 47 of 59 patients, 80% of the patients, developed renal failure, infection, or electrolyte imbalance, or a combination. The mean volume of fluid drained per day was about 3 liters because these just continued to drain. And so half of the patients died in a period of 3 months. Most of them died actually a lot earlier. Now, if you look at the next slide, there is the use of tunnel pleural catheters in the study format was done from 2011. We've already discussed studies number 1 and 2 on this table, but if you look at study number 3, Chen and colleagues, that's the only study on hepatic hydrothorax that has looked at tunnel pleural catheters in a prospective fashion. And if you look at the arrow, the red arrow on the top, looking at patient-centric outcomes, none of the current studies in the setting of hepatic hydrothorax have actually looked at symptoms or looked at outcomes that patients care about. And I think this is important to point out. So let's look at some of these studies. If you go down to the next slide, please, David or Ara. So this is a study by Chen and colleagues. It's a pilot study, 24 patients, prospective, so very important. Mean number of thoracentesis before catheter was placed was 2. They showed 33% pleurodesis rate in about 132 days, median of 132 days. And pleural infection was noted in about 17% of the cases. And among these 24 patients, 5 of them had liver transplant. Bear in mind it's a pilot study, so it's a small sample size. It's a single-center study, so the external validity of the study is not as well as we would expect it to be. And the primary endpoints were not patient-centric endpoints. Now, if you look at the next study, the quite recent study by Knies and colleagues, they also looked at the outcomes of tunnel pleural catheters in patients with hepatic hydrothorax. They included 62 patients. 33 of these patients received the catheter as a bridge to transplant, and 24 of them for palliation. And they noted pleurodesis rate of 14%. I believe 5 of these patients were actually transplant candidates who got their catheters out after transplant. The mean time to pleurodesis was 118 days. And if we move to the next slide, please, we can see that in terms of complications, They range from infection, which is the most common complication, empyema at a rate of 16%, to other catheter-related complications such as catheter getting clogged or dislodged. And they noted that some of the infections were questionable. It was possible that some of these infections were actually secondary to spontaneous bacterial empyema. All right, so let's move to the next slide. I think this is a very nice graph. The risk of malnutrition is a real risk with drainage of the pleural space on a regular basis because of the loss of protein-rich fluid. And as you can see here, the authors showed that both BMI and albumin dropped from pre to post IPC placement. Now, the importance of these numbers are still not known, but I think it's a step towards the right direction because many of us ask the question of the utility of albumin use in the setting of volume pleural space drainage. As most of you know, large volume paracentesis when followed by albumin results in decreased circulatory dysfunction. And so many question that albumin use after IPC drainage of the chest may have similar effects. Let's move to the next study. So this study looked at a very similar outcome, also retrospective, but a multi-center study in 8 centers. 75 patients were included. I apologize, there is a mistake here. 58 patients were palliative, actually not bridge to transplant, and 21 patients here were included as a bridge to transplant. The spontaneous pleurodesis rate was reported as 28%, and the median time to pleurodesis was 55. I've underscored median here because I think there is a great likelihood that the actual time to pleurodesis is probably closer between this study and the last one. The only difference is that the last one reported mean, and this one is reporting median. But if you look at the range of days, there is a patient here who actually pleurodesed in 10 days, and a patient pleurodesed in 370 days, which is why it may be helpful to get a better picture of that true number of days to pleurodesis if we look at a median because of the non-normal distribution of the data. If you look at the graph on the side, you'll see that one patient actually had their catheter in place for about 1,978 days, nearly 2,000 days. All right, let's move to the next slide. So this slide is looking at complications of catheters. One of the main concerns with conventional chest tubes has been renal failure and electrolyte imbalance. And I think the hypothesis is that use of IPC decreases that possibility because the drainage happens on a daily or every other day basis, but it never exceeds 1 liter. Most of these studies have focused on just draining enough fluid to provide symptomatic relief as opposed to emptying the chest and providing full re-expansion of the lung. And so as you can see, the rate of renal failure and electrolyte imbalance is much lower than the conventional chest tubes. Empyema was the most common complication here, 10% rate of empyema, and 2 patients died as a result of empyema-related sepsis. Now, I have to note that one of these 2 patients who died was a transplant candidate who probably missed the opportunity to go through transplant because they died earlier due to their catheter-related sepsis. All right, let's go to the next slide. So, I apologize. So we're looking at the reasons for tunnel pleural catheter removal. And what is done here is taking into account other reasons for catheter removal as competing risks. So infection, catheter malfunction, and death as the other 3 reasons for catheter removal are taken into account and compared with catheter removal due to pleurodesis. I want to point everyone to that one line that is in purple that says 11 post-transplant. So the pleurodesis rate in this study was reported as 28%. 22 patients were considered to have pleurodesis, but 11 of these patients were post-transplant patients. I think this study and other studies that have looked at patients with hepatic hydrothorax defined pleurodesis as 3 consecutive times that a patient does not have fluid drainage through their Pleurex catheter, and then examination of the chest, no pleural fluid, I'm happy. I take the catheter out because I think there's pleurodesis. I think what we missed out on is that we considered malignant pleural effusion to be similar to these patient population. The truth is that when a patient undergoes transplant, you immediately take away their portal hypertension. And so the resulting pleural effusion goes away, not because there's pleurodesis necessarily, but because there's no more pleural fluid collection in that space. So although based on the definitions of this study, the pleurodesis rate was 28%, I think this number is overinflated. I actually think that the actual rate of pleurodesis has got to be much lower if we were to exclude the transplant patients. Let's go to the next slide, please. So survival data on IPC, the only purpose of this is to show that even in the setting of IPC, patients who are receiving IPC just for palliation overall do worse compared to those who receive transplant. In the first graph, there are transplant and palliative patients all together. In the second graph, there are only palliative patients. The only reason there's no graph with just the transplant patients is because out of 15 patients who received transplant, only one of them died. All right, so in terms of limitations of the study, one positive thing is that because it is a multi-center study, there may be more external validity. Limitations are numerous. It is a retrospective study. It has not accounted for the selection bias in different institutions. There was a patient in an institution that had 40 thoracentesis before a decision was made to put a tunnel for a catheter in. Some other centers had decided to put a catheter after 2 thoracentesis. So these are important to keep in mind. There is significant selection bias that is just very hard to adjust for in the setting of a retrospective study with institutional and operator bias. All right, let's move to the next slide. We're almost done, I promise. And I apologize for the disconnect with network and the slides. So IPC and other non-malignant effusions, the purpose of these other slides is to just show what else is available in the literature. These are very, very few and small studies. Use of IPCs in end-stage renal disease, that's next slide. What slide do you have, David or Ara? Do you have indwelling?
So I'm on the slide with indwelling pleural catheters for pleural effusions with end-stage renal disease. Fantastic.
So this is a retrospective case series, 8 patients, 9 catheters. All I want to point out is that this this patient population has received tunnel pleural catheters in the literature. As you can see, there's just a report of 8 patients. So we don't know enough about this patient population. We do know that at least in this study, some of the patients did have pleurodesis. Let's go to the next slide. This next slide looks at the utility of tunnel pleural catheters in patients with infection. Again, I think the authors should be applauded for this study because they thought of using tunnel pleural catheters in 2008 for patients with empyema. They reported 2 patients. One of them had bronchopleural fistula and a hydropneumothorax with an infected chest. After many attempts to manage the chest, they put in tunnel pleural catheter. After 21 months, the patient improved. And if you look at the next slide, this is their second patient with tuberculous pleurisy who had 8 months of tunnel pleural catheter before the catheter was removed. Looking at the next slide, we've already seen this table with empyema in 9 patients. This was a multi-center study, so every center contributed to some of these patients. The point is that IPCs in the setting of empyema are not necessarily desirable. Are they my first choice, second choice, third choice? Probably not. But if there are no other options and a patient needs to stay in the hospital with a chest tube, it is possible to send the patient home with a tunnel pleural catheter, something to just consider. Looking at the next slide, role of tunnel pleural catheters in chylous effusions. Again, I want to point out those 2 areas where the red arrows are, prior intervention. These are all benign chylous effusions, but I want to show you that many interventions were performed for these patients before a decision was made to put a tunnel pleural catheter in, from serial thoracentesis to diet changes to thoracic duct ligation or embolization, mechanical pleurodesis, or diaphragmatic repair. these were used as the last resort, and as you can see, there was a 64% pleurodesis rate. Again, small case series and retrospective study. And finally, last study, use of tunnel pleural catheters in patients with solid organ transplant. This is a case-control study, 19 patients who were post-transplant, and there was a heterogeneous population of different transplanted organs, was compared to 55 non-transplant patients of different underlying etiology for pleural effusion. As you can imagine, the concern is that these patients are immunosuppressed. They're on immunosuppressive therapy post-transplant, and they had definitely reported their 90-day infection rate at about 16 to 17%, but the difference with the other group was not significant. And the mean catheter time was fairly long, 148 days. So again, a possibility, again, retrospective study, and the number of subjects that are included in each group are fairly heterogeneous. All right, let's look at the next slide, David. So just to summarize, first of all, as we mentioned, the data out there is very, very limited. And as we noticed, most of the time where IPC is used for patients with non-malignant effusion, it is used in the setting of true refractory disease, and that's why I've underscored refractory, because all other interventions should have failed. Interventions that have more literature to support their utility should have been used and failed before plans for tunnel pleural catheters are placed. This is more a personalized approach in addition to using the literature in a very critical fashion. If we look at the next line or the next slide, tunnel pleural catheters, excuse me, in heart failure have higher pleurodesis rates than hepatic hydrothorax. And next line, tunnel pleural catheters in hepatic hydrothorax have significant complications in transplant candidates. I think this is very important. If you consider tunnel pleural catheters in this patient population, it's important that a multidisciplinary session is in place so that your transplant surgeons and hepatologists are on board and understand the risks and benefits of this treatment. In the next slide, we notice that generally the current data that is available suggests every day or every other day drainage with the goal of symptomatic palliation. The goal is not to empty the chest in this patient population. Often after drainage, there is still a large volume of fluid in the chest of a patient with hepatic failure or heart failure, but there is still some symptomatic improvement. And finally, in the next slide, you'll notice that the role of albumin is still unknown. And so whether you use albumin or not, you're really not wrong in using it, and you're not necessarily right in using it. There is no literature to support pro or against it. All right, so next slide, looking at what is missing from the literature. I think everybody's noticed, just reviewing what we have, is that we have so far been limited with regards to our analysis and our studies. We do need prospective data. We need randomized trials that would compare IPC with other methods of therapy in patients with CHF and hepatic hydrothorax, perhaps using homogeneous population of patients. So one different etiology, one different category or group of patients. And can you show the next slide, David? In terms of primary endpoint, I think one of the most important things to take away from this talk also is we constantly talk about pleurodesis. That's what you see in every single study. What was the rate of pleurodesis? And I wonder if the patient cares about pleurodesis at all, as opposed to true palliation. I think future studies should focus on quality of life, dyspnea score, and changes in dyspnea scores, number of days that a patient needs to come to the hospital. I suspect that we are a bit biased with our view of, we assume that if a patient doesn't need frequent source and pieces, they've got to be better, but we should consider the requirement for hospital visits secondary to complications of catheters, the change of the color of the fluid, which should concern the patient, and many different things that we don't account for. And these, I think, should be studied prospectively. And with that, we're in the next slide, so we're done. I apologize because I'm completely disconnected with everybody else. I really don't have a network, so I don't see any comments or anything whatsoever. I'm so sorry.
Thank you. Thank you, Dr. Shojaee. No problem. We'll wrap this up here for you. So really, that was really as comprehensive of a literature review as possible, I think, for this topic at this time. That was really great. While we're a little short on time, but while we wait for maybe one or two additional questions from the audience, I have a question, just kind of a broad process question, and you kind of already alluded to it in your closing comments in regards to the hepatic patients. But as we all know, we all see a lot of these recurrent non-malignant effusions in our respective inpatient services, many of whom come from the internal medicine services asking for IPCs. And at least at our institution, very frequently these patients have not had proper subspecialty follow-up. In your practice, do you mandate a multidisciplinary discussion with the relevant subspecialty services before considering an IPC, even if medical therapy appears to be maximized?
So I personally do, and I don't necessarily. I make this a multidisciplinary approach, at least from the perspective of pulmonary and the primary team that is connecting with us, and then the downstream subspecialty that is dealing with the underlying problem. So if the patient is, let's say, admitted to medicine and the hepatology and the transplant team is following up, at least in our practice, we never put a tunnel per catheter in a patient with hepatic hydrothorax unless we have an approval of a hepatologist and a transplant surgeon. Because we have a protocolized approach towards these patients, it is often when we suggest the tunnel per catheter, we do it very carefully. We talk to patients very at length, and then we talk to our transplant surgeons. Given they are aware of the data out there and they know what's going on with regards to risks of different patients, they weigh in, and then everybody goes in with a very informed, making an informed decision, including the patient and their families. I disclose with patients and their families all the risks, the limited literature, possibility of infection, possibility of catheter preventing chance of potential future transplant, and all of those risks are disclosed upfront. Yes, so we do approach it in a multidisciplinary fashion.
Excellent, and extremely wise approach. Couple of questions, and then we'll wrap things up from the audience. First, it regards IPC versus pleurodesis for chylothorax. What are your thoughts, and is there any evidence comparing the two?
So, great question. There isn't much evidence comparing the two. There is some evidence looking at pleurodesis in the setting of chylothorax. There is actually a study looking at the benefits of or the treatment of chylothorax in the setting of malignant disease. And so the two are kind of different. There are studies that have looked at, there's actually a study from MD Anderson that has looked at chylothorax in the setting of malignant disease. And there's limited data in this area with regards to pleurodesis, as well as the rate of pleurodesis after tunnel per catheter placement. But there is no paper out there that has compared the two in a head-to-head fashion, comparing tunnel per catheter versus a group of pleurodesis in chylothorax alone.
Perfect, thank you. Looks like we have one final question before we wrap things up. So what are the issues, if any, of getting payers to cover cost of the drainage bottles in the non-malignant population?
That's a great question. We in our center had a lot of difficulty in the beginning approving catheters to be used and covered by insurance. I can tell you that we have, I feel very protective of this patient population. They are often just as bad as a patient with malignant effusion and require and need palliation just as much. And so I found it originally quite disturbing that their insurances wouldn't cover it. Some insurances still do not cover management of effusion with tunnel per catheters. I think we originally found ways around this. I encourage, if anybody's on the phone, I encourage them to talk to their tunnel per catheter reps, whichever one of the catheters that they use. Each one of these groups actually have a compassionate, or they have a team that takes care of patients who cannot have insurance cover their catheters. There are some changes with regards to the use of catheters. There's actually a year or 2 years ago, there was a new statement and FDA approval for use of catheters in benign effusions in the setting of cardiac failure or heart failure and induced effusion. And I think that most of these catheter companies, whatever the type of the catheter is, have been able to help accommodate patients who don't have a supportive insurance.
Excellent. Awesome. Thank you, Dr. Shojaee, for really those thorough and insightful answers. I think we're out of time. Before we wrap up completely, I want to turn the mic back over to Dr. Shah for our closing comments.
Great.
Thank you, Ara, and of course, thank you again, Dr. Shojaee, for sharing your experience with us. Obviously, a couple of announcements. Number one, as you see on the screen, that the second conference of the AABIP will be held in Denver, Colorado on August 15th to the 17th, 2019. So please save the date and look out for more announcements related to that conference. Also on your screen, you can see the upcoming tentative dates for the next webinars in the webinar series. We'll have Dr. Gerard Kreiner, or Jerry Kreiner from Temple University, who will be talking about bronchoscopic lung volume reduction for emphysema in February. And then in March and April, we have 2 anesthesia-related talks with regards to their integration with our IP patients. So we thank you all for joining us tonight, and please look to your email announcements for those upcoming activities. Thank you, everyone, and have a wonderful evening.